It is now my honor to introduce to you Dr. Ken Ramos. He is a globally recognized physician scientist whose work has transformed our understanding of genomics, precision medicine, and toxicology. A member of both the National Academy of Medicine and the National Academy of Sciences, Dr. Ramos is widely respected for his leading-edge research into the molecular mechanisms of disease. Dr. Ramos began his research career exploring the fundamental mechanisms of cell injury, but his work soon evolved to emphasize translational science and technological innovation. Dr. Ramos held key leadership roles at the University of Louisville, where he served for more than a decade before being recruited to the University of Arizona. In 2014, he joined the UA as Associate Vice President for Precision Health Sciences. His work in genomics, predictive biology, environmental and molecular medicine, and toxicology at the UA led to his election to the National Academy of Medicine. He also served as interim dean of the UA College of Medicine Phoenix during his tenure. In 2019, Dr. Ramos took on a new leadership role at Texas A&M University, where he currently serves as Executive Director of the Institute of Biosciences and Technology and as Assistant Vice Chancellor for Health Services. In addition to his research, Dr. Ramos is a transformative academic leader and mentor. He has guided countless clinicians and scientists across disciplines and is deeply committed to advancing the use of modern technology to improve healthcare quality, reduce disease burden, and make care more equitable and cost-effective. Today, as the physician executive at Texas A&M University, Dr. Ramos continues to shape the future of medicine and public health. Please join me in welcoming back the 2025 Eva M. Holtby Endowed presenter, Dr. Ken Ramos.
So one of the bad things about this podium is that it will lock me here if you want to hear. So every so often I might just swing sideways, and if that's the case and you can hear, please let me know. Tracy, thank you for that kind introduction. It's always a pleasure to come back home and see, colleagues and friends that I've come to build a very strong relationship with over the years. So I was waiting here for this, just ran into Mary Weinstein, who ironically was one of the people that I ate dinner with the first night that I arrived in Tucson many years back, and so it was a treat to have a chance to do that. As I was engaging in the breathing exercises that we were doing, it reminded me of a couple of things. The first one is that I'm a pulmonologist by clinical training, and so obviously breathing is an important piece of what we do, except that we don't teach, the good breathing exercises that you just learned. But the metaphysical meaning of breath really translates into the ability to be ready for the ingestion of knowledge and insight. And so hopefully the remarks that I have to make today regarding precision medicine will inspire some of you in ways that will empower you to take charge of your own health. And if you work in that space, commit yourself to maybe making a difference in this particular space. I should also say before I begin that I was privileged to give this keynote before I left Arizona, actually. I remember Tracy sort of finding out that I was getting ready to go back to Texas as we were preparing for the lecture. And some of you might be inspired to know that during that visit, I learned about integrative medicine. And it dawned on me. I spoke about precision medicine, of course, 10 years ago, right? Which means that lots have changed, hopefully for the better, in the field. But it dawned on me at the time that there's no way that you could do precision medicine if you do not do integrative medicine as part of it. And so my message to you will actually carry some of that forward. In fact, I was so inspired that I went ahead and did the Integrative Medicine Fellowship here in Arizona while I was in Texas. Should have done it when I was here, but better late than never. And so I share a lot into the mindset that I think Susan shared with us. In thinking about today's talk, and knowing sort of the great work that the Arthritis Center has done over the years in educating communities, educating patients, empowering patients, I was thinking about how best to convey to you the complexity of the field, but make it sort of digestible in ways that become relevant, and useful. And so hopefully what I'll share with you will be able to do that. I also must confess that the title of my talk is actually Tracy's ingenuity. She suggested this title and she said, "Do you like it?" I said, "I love it." And so hopefully you guys will love it as well. So essentially our job this morning is to try to begin to crack the code. And as you know, coding can take many different, dimensions. If you're a computer scientist, coding, means, writing the algorithms, that will drive what the computer does, basically creates the intelligence to that process. But human bodies actually are essentially computers, and the wisdom of nature and God, for those of you that believe in God, created a code, and that we call the genetic code. And so what we're going to do is try to migrate through a quick journey as to what that code represents. It might be, sort of a repeat of things that you've heard before, but learning requires repetition. And then I'll introduce you to some of the new aspects to cracking the code and how precision medicine has continued to advance and transform the practice of medicine. I do want to leave you from the outset with one important message, and that is medicine in the way that we practice today is likely to continue to change in very meaningful ways. And a lot of that really is a function of these little devices that we carry with us. By way of hands, how many of you carry a smartphone with you? So that's literally a universal, sort of adoption that we've engaged in. And I'm sure that some of you, when cell phones, first came out, sort of went like, why would I need a phone for? I've lived, 40 years without a phone. Why would I need that for? And now you have a panic attack if you cannot locate, that little device. And so the same thing, I think, is going to happen to medicine. And in fact, a lot of the changes that are being driven by precision medicine will take advantage of that type of technology to be able to do its job. So let's get started. From my perspective, the story of precision medicine began when there was completion of what we called completion, quote, quote, of the Human Genome Project. Many of you probably have seen that. This was a huge investment of resources, about $3 billion worth back in the day, probably $6 billion, in today's dollars, that took about 13 years to complete, quote, quote, because it never really was completed. It continues to evolve and change, but complete because you could make a report out of it. And in 2003, it made splash news, throughout the world, because the U.S., in partnership with other countries, have been able to come up with the sequence of the human genome. And so basically what that did was it took the remnants of what we knew about genetics, at the time, and the understanding we had of genetics at that time, and distilled it in ways that people could actually begin to use that information to start gaining additional insights into human biology and, of course, into disease. And so if you think about it, what the Human Genome Project did was essentially it wrote a book. And that book basically was the letter sequences that basically carried the code of the genome. And they called it a code because we use 4 letters that simply, are A, C, G, T. And the sequence of those letters and the order of those letters across the genome defines how the genome operates. And so it is, in fact, a code, right? Because it's a sequence of letters that is guiding action, much like the way the code does for a computer. And there was huge excitement and huge promises made, and the big splash was made. And then after the excitement settled, what we realized is that was really just the beginning of the process, that we really did not understand at all what the genome was all about. And that having the book written for the reference genomes that were generated in the early days was only the beginning of our understanding of how do you use that code to make good for people and to help treat disease and to help to prevent disease. And so I think a lot of important lessons, came from that. One of those lessons was that having the sequence of the letters and having the code did not tell you anything about how the code was read, nor what the codification actually was intended to do. And just to exemplify that point, one of the biggest surprises was that our genome was not the most sophisticated genome. It was really cool, right? We thought we were going to have the most number of genes of any organism because we're so superior to everybody else. Well, it turns out that water fleas have better genomes than we do. Bigger genomes, And I now come from Texas, so bigger is not always better, right? So that actually was a huge important lesson, and it sounded kind of simplistic, but what it taught us was that size or sequence was not enough for you to unravel the secrets that the genome was codifying for. And so a second project was created that was called ENCODE, and that starts for the Encyclopedia of DNA Elements with the idea that now we would utilize that code that we had in hand to begin to understand the functionality of the genome. Because you needed the functionality of the genome to actually be able to use that information to make inferences that led to healthcare decisions. And ultimately the goal has always been to utilize this information for the benefit of mankind. And so here's an example of a little bit of that complexity. And I just wanted to make sure that I introduce you to this in case you've never seen sort of what that DNA and what that sequences that I just showed you before really looked like in functional terms. The first thing that you probably would notice there is that you basically have like a whole bunch of grapes wrapped up in like a blue film around it. Do you see that? The grapes, on the films? Well, it turns out that we pack a humongous amount of DNA into a tiny little bitty cell. And the way that you do that is by wrapping it around on itself, essentially coiling it in a way that basically wraps around itself. And that contrary to what we understood 100 years ago, you had to have interactions between proteins and DNA to be able to execute that, function. The nuance came from the fact that the sequence of the DNA itself is not sufficient to define the functionality of your genome. And so that's when genetics sort of expanded to become genomics. And in that expansion, the biggest realization that was made is that tags that were put either on the DNA itself or on the proteins where DNA was wrapping itself around were really the signals that dictated how the genome operated. And so it opened another kind of worms, and we're continuing to unravel what we now call the epigenome, which basically stands for sitting on top of the DNA. And it's these tags that are shown in the cartoon, depicted as DNA methylation, chromatin modifications, DNA's hypersensitive sites, that basically define how the genome operates. And so you can imagine that the disappointment was huge, right? Because we thought that once we completed that $3 billion project, we had the book and that we could actually start using that book to make differences in people's health. But the reality is that we still had a ways to go. We're now in a much better place than we used to be. So the news continued to be positive. And so the last sort of concept that I wanted to introduce relative to the complexity of that genome actually is an area that I've been working on for about 25 years, so it's a little bit close to my heart. And it's the idea that genomes are not static. We used to think that nature defined how we behaved and what diseases we got. But the reality is that that's not always the case, right? You know, it's sometimes the case, but it's not always the case. And it actually explains, I think, the uncertainty that many of us actually have when we treat any one particular condition, or when you are suffering from a particular condition. And that is because your genomes are continually evolving. And those genomes evolve as a function of the things that you do, the choices that you make, the things that you eat, the emotions that you feel. And so even though it can become somewhat, unsettling to think that your genome is changing so dramatically on a minute-by-minute basis, the empowering aspect that comes from that is that the choices that we make and the decisions that we carry for ourselves can actually help our genome behave the way that it needs to behave. And so I think that's a message that hopefully will carry forward, with you. The last thing I'll say regarding that particular, cartoon in front of you is the fact that nearly 50% of our genome moves around and has the capacity to shift and change. And so I've devoted many years of my life trying to figure out how do we use that knowledge to be able to control disease and change disease trajectories. And so this particular slide, basically, it's an example on Parkinson's disease. But the same figure could be made for arthritis. The same figure could be made for scleroderma. The same figure could be made for heart disease. And that is the fact that there are trajectories of disease as a function of time, as a function of our own growth and our own aging, and that because of the feature of the genome that I just quoted for you, which is the fact that genomes are not static and that they respond to the choices that you make, it's up to you to decide where on that curve you are. And that's really empowering, I think, right? Because in the old days, we used to think of genetics as basically deterministic biology, right? You were born with a bad set of bad genes that your father and your mother gave you, and there was not very much that you could do to change that. Well, now we know that's not true. I mean, there's some baggage that you carry with you, right? Because your parents gave you that. But there's things that can be done to change what that baggage does for you. And if you could not totally eliminate risk of disease, and of course the reality is you can't, right? We're all prone to, ending up sick of something. You could actually influence what the shape of that trajectory looks like. And that knowledge, I think, is essential for us to make a difference in healthcare today. And so what is true for Parkinson's disease is actually going to be true for many of the conditions that people sitting in this audience are interested in. And so that takes us then to one of the take-home messages that I want you to take with you today. Something that I think many of you already know, but that hopefully my comments can help reinforce and empower you to continue to move forward. And that is that your environment and your lifestyle and the choices that you make are what define what your genome does. And so this is a lesson that, of course, those of us in the audience who are, past the age of 40 appreciate very much, right? But maybe what we need to do is start teaching this lesson to people when they are 2, when they're 3, when they're 4, so that they don't make some of the mistakes that some of us have made in our own life journey. And so a take-home point is the fact that because of the flexibility of your genome, because of the plasticity, that's a term that we use, of your genome, you have the capability of actually changing trajectory of disease. And I'll give you some concrete examples, to that. Plasticity is a good word to remember regarding this concept, because it reminds us that have any of you seen somebody who had a stroke, lost a lot of function, and then all of a sudden, because of perseverance, training, and rehab, was able to regain that activity, and the brain was able to recover, and the person was able to go back to a somewhat good life? That's the kind of flexibility of your genome that we can exercise at all levels. Obviously, some organs have more plasticity than others, but all systems, I think, can benefit from that, same concept. And that brings us, I think, to a very important point. We think sometimes that biology defines what illness is all about. But the reality is that non-medical determinants of health account for more than 70%, some people say up to 80% of health outcomes in individuals. And you have a cartoon there in front of you, and you could pick whatever is that it's your favorite item to modify. I was having a conversation with one of the people in the audience who made reference to the fact that in order for her to regain health, she needed to change her job. For whatever reason, that was. Some people, need to, change where they live. So some people need to change what they eat. Some people need to change a company they keep. Some people need to change, some habit, that they have. But the important message there is that you have some very significant determinants of health that are really under our control. Most of the time, not all the time. And that can actually make a huge difference in your life. And then an ancillary point to be made is the importance of culture in the way that health and disease are managed. And here in Arizona, that's, I think, a very important message because of the huge diversity of cultures that we have, in the state, and the difference in backgrounds and the difference in habits that we experience. Well, there you have a listing of all the things that culture can actually impact. It can change perceptions of health, illness, and death. It changes beliefs about what causes disease, changes approaches to health promotion, how illness and pain are experienced, where and how patients seek help and how they respond to the recommendations that the providers make, and the types of treatments that patients, prefer. And all of those are elements that need to be factored in when you actually have a patient encountered. And so here comes, precision medicine. Some people call it precision health. Some people call it personalized health. Some people call it individualized health. And all of it really shares one important concept that I think is the point that I'd like to emphasize for you. And that is that what makes precision medicine special is the fact that we are making efforts to integrate all of the information that we know pertains to, to a patient's health, to try to use all that information to make clinical decisions and to make recommendations for patients. And so in a system that focuses a lot on treatment of disease, that's powerful because actually it makes the effectiveness of that treatment that much better. But we are slowly and inevitably changing towards a system that really needs to be focused on prevention. And we need to start thinking about prevention not because of the altruism of we all want to look healthy and young forever, but simply because we can no longer afford the healthcare system that we have. We have great technologies, and they're great when you need them for an acute management, but they're not great to manage chronic disease, which is really the big problem that we face. And so precision medicine is a term that was coined to basically create a comprehensive platform that allows healthcare delivery to be delivered using all of the information that you could possibly get out of a patient. And the bad news is that human brains are not enough to be able to carry all that information and to use all that information. So your doc, no matter how good that doc is, cannot do it alone. We need technology to be able to do it. And so the transition that we're going through right now is how best to use technological advances for your providers to make better informed decisions and give you the remedies that you need at any point in time. And so precision medicine can take many different phases, many different dimensions. You could use precision approaches to improve the diagnostics of disease. Many of you, I'm sure, that have heard of diagnostic odysseys. In fact, people in this audience probably were patients that went through multiple doctors before you arrived at a diagnosis. So genomics and precision medicine approaches can actually help you with that. We can improve targeted therapies. The idea that one size doesn't fit all, right? That's sort of one of the mantras of precision medicine. Why? Sometimes you take the same medicine that the person next to you took, and it doesn't work for you. How do we make better choices in terms of that, medication that's being prescribed? Optimization of clinical management through clinical decision support. Let computers help us out. And of course, I have some remarks to make about artificial intelligence and how artificial intelligence is going to be changing the way that we carry out our business in the future. And so you could read, the remainder of that list. The point being is that every level of your medical journey can be touched by the technologies that are embraced under the precision medicine platform. You all with me? All right. And so I've already alluded to the fact that one size does not fit all. And so in many ways, what precision medicine is doing is changing where the magnifying glass is placed on a particular patient. And rather than basically relying on symptomatology or basically the description that you read in a book, you actually take insights into the inner workings of the individual's body in ways that hopefully enable you to make a better choice. And that you move away from the idea that one size fits all for any one treatment or recommendation that you make, to the idea that you need to tailor to the individual patient that is in front of you. Now, I don't mean to suggest that medicine has not been personalized before. Medicine has always been personalized, right? Medicine has always paid attention to the patient that's sitting in that room at the time that there is a clinical encounter. The difference is how good a magnifying glass that clinician has in seeing through that patient. And at the end of the day, hopefully preemptive testing, whether it be genomic testing, whether it be radiological testing. Now, I'm sure that many of you have seen diagnostic MRIs offered for $1,000, just to make sure that you kind of see what's going on, inside your body. hopefully those are the technologies that we're going to be able to make accessible, for all. So there's a number of tools that have actually gotten us to where we are today, and those are listed here in this particular slide. Notice that I started with machine learning and artificial intelligence as the top bidding in that list. And the reason for that is, I've already alluded to it, human brains are not good enough to be able to take massive amounts of data. We're talking millions, trillions pieces of data for one individual and then multiply it by the population of the US, right? 350 million people. So imagine the size of these data sets. And a human brain cannot distill that information to make, heads out of tails. But computers can. And so I'll give you some examples of that in a few minutes. Social and behavioral approaches, the integration of social behavior into medical decision-making, omics technologies, as that's where the genomics is. So a point to be mindful of is precision medicine is not just genomics. And that's one of the sort of the fallacies, out there. You tend to equate precision medicine with basically genome sequencing. And as important as genome sequencing is, it's not the only thing that precision medicine, drives. And in fact, making a difference in people's lives through precision medicine approaches probably benefits most from other interventions more than omics themselves. I've already alluded to clinical support, big data, electronic health records is a good example of that, because now you have longitudinal data on patients, as opposed to having to flip back to 100 pages, and then read that. And then patient education programs like the ones that we have here. Artificial intelligence and machine learning. Well, huge controversy right now, right? Have you seen the ads on AI in medicine? What is this going to do? Do you really need your doctor anymore? And I'd be curious to hear, during the Q&A, what your thoughts are about that. But I have some thoughts that I'd like to share with you on my own insights, related to this. We, as a society, have been more receptive to technology acquisition than anybody would have predicted in the past. Do you agree with that statement? I remember when microwaves came out, why do I need a microwave? Well, now I can't live without one. When cell phones came out, why do I need a cell phone for? Now I can't live without a phone. Computers. They used to be not friendly. I remember having to stack up 1,000 cards, and they had to be in the right order for the computer, and the computer was the size of this room that we're in right now, and if the card was out of place, the program wouldn't run. And now we just click, and we get aggravated if the internet doesn't respond very quickly. So that means that there is some adaptability in the human brain that enables us to embrace technology, and medicine and healthcare is no exception to that. The real challenge is understanding enough about the technology and what it can do for us so that we can actually take full benefit of what it can do. And then, of course, some of the nuances that go with technology and acquisition. Let me take a few minutes to define for you what I think are the differences between artificial intelligence and machine learning. Fair? Artificial intelligence refers to functions that we normally attach to a human brain that the computer can do for you. In fact, some people are calling this generative AI, meaning that it can actually generate new insights, thinking the way that we think. Machine learning basically takes big amounts of data and tries to make sense of that data in ways that we can actually interpret and use in a meaningful way. So in some ways, machine learning is a sub-component of what the artificial intelligence world is all about. How many of you have already used ChatGPT? Yeah, a lot of hands in the audience. So there's Perplexity, Claude, Gemini, Copilot. all kinds of, algorithms out there. Well, the healthcare industry has taken notice of that. And we are using that information to deliver precision healthcare, taking advantage of artificial intelligence and machine learning. And hopefully that will continue to make a difference. But this is the only slide that I'm going to read one by one. So if you indulge with me, we're going to walk ourselves through this one slide. I very seldom put complete text slides in any presentation that I give, but I felt compelled to do it for this presentation because of the recent promotion of AI in medicine and all the questions that remain relative to its integration into healthcare. For the providers, a very welcome addition of AI is the fact that maybe we will not have to be clicking on the computer a million times anymore, as I'm sure you've heard providers complain about. So maybe AI can actually create our notes, create the records for you, that you take with you after a clinician, has had a chance to review and approved, what the AI algorithm has developed for you. Sounds like a winner to me. And I bet you that many of you would agree to that. A caveat to that is that the technology partners that help build and engineer the technology that we end up using in a patient encounter need to abide and play by the same rules that the medical establishment plays by. And I'm sure that many of you are very sensitive to the idea of data privacy, data security, and who can access, that data. And so I think there has to be enough guardrails put in place so that the technology can be used for its good and not misused. Healthcare systems like the University of Arizona, like Texas A&M Health, like Vanderbilt, even private payers, need to develop a long-term vision for how we're going to use the technology, when it is appropriate to use the technology, and the integration of that technology into healthcare delivery. And believe it or not, those decisions have not been made. This is one of those issues where, the horses are out of the stables, but nobody really is paying attention. I've already covered the data governance piece. Data availability for clinical research, as you know, is critical. The Arthritis Center is the epitome of, clinical engagement in clinical trials for patients. But I think we still have issues related to de-identification of data and access to large databases that will continue to be an issue. And the last thing that I'll say is that analytics companies are, very closely working with hospitals to use AI to actually improve quality of care. And remember when I was making reference to the fact that healthcare is unaffordable? Maybe AI can actually help us overcome some of the problem. And the reason for that is there's inefficiencies in the system that sometimes escape recognition that AI may be able to identify. Turnover of beds, in an ICU unit. Prediction as to how many beds are going to be available at any one point in time. Staffing issues. Sometimes you don't want to have too many nurses in one floor because you actually need them on a different floor, and AI can actually help with making some of those decisions. Efficiency and expediency with which you go through a clinical encounter. All those are issues that AI can actually help. So, bottom line, I actually think that the integration of AI into medical practice is a welcome addition, and that we just have to manage that integration in ways that hopefully helps us make a difference. And so the whole idea of AI and machine learning has led to a new term, and now we call that new term digital medicine. You actually have experts here at the U of A in digital medicine, and very terrific contributions have been made from the University of Arizona in this particular space. A question that you guys are going to have to wrestle with is, do you really want your doctor to be that digital doctor that I have on the slide? Or do you want somebody with flesh and bones and a human brain attached to it, managing what that does? And I think those are decisions that will have to be wrestled with as time, progresses. Have you guys heard of digital twins? Not yet? Well, that's the new kid on the block in the digital medicine space. And so essentially, what the computers are doing is creating a digital version of you as a patient. So remember, how many of you saw Avatar, the movie Avatar? Many of you, right? This idea that somehow the psyche of this human could be integrated into this avatar. Well, essentially that concept. The difference is that we will take all the data that we can assemble out of a patient, and that includes all the social determinants of health, all the genomic data that I told you about, all the choices that you make, all the histories that we provide, family histories and so forth. Take all of that complex data, stick it into the computer, and allow the computer to create a digital you that can actually generate predictive information about trajectory of illness, response to treatment, and make adjustments in real time that then your doctor can actually manage down the road. Kind of exciting, but at the same time, quite intimidating. And of course, don't want to miss the opportunity to mention telemedicine, because Mary, in recognition of Ron's, contributions, of course, U of A was actually one of the pioneers in developing telemedicine capability for access to care. And that's an example of how technology really has transformed and improved the quality of care. Some of you are carrying these watches, because I saw some of you wearing them. This is the newest kid on the block in terms of digital, technology. Pricey right now, but as you know, technology essentially prices, drop over time, and sometimes at an accelerated pace. And so very soon, many of us are going to be wearing these devices, whether it's the Aura Ring, whether it's the smart, Actigraph watch. And the real value of this is that as technology advances, the data that's recorded from these devices can directly go into your electronic medical record. And then if you have your digital avatar, that digital avatar can take that data and use that data in real time to actually improve the quality of care that you receive. And so very soon we're just going to be getting alerts, from the doctor's office. You need to watch, the fact that you were not breathing deep enough, and that Susan, might be needed as a consult, because your breathing was not exactly what it needed to be last night. And so you better make up for it in the rest of the day. Yes, absolutely. Another important addition to the repertoire of precision medicine is what we call pharmacogenomics. And this goes back to that concept of one size does not fit all. I'm sure there's plenty of examples in the audience about when you took that one pill that didn't do what it was supposed to do for you. And very oftentimes, the reason that pill didn't do what it was supposed to do for you is because your genome did not allow the pill to do what it was supposed to do, because the majority of people that respond to it have a genome that is different from yours. So you can customize drug selection, you can customize drug therapy, taking advantage of insights coming from your pharmacogenome. And this is a subset of about 200 genes that basically define the way that you do it. And basically, the concept behind it is identify which of those colors is it that you really belong to, so that you could match the color that you have with the therapy that you get. Now, there's one caveat to this. We have to make sure that this does not become VIP medicine. and this, I think, for states like Arizona is an extremely critical point. We must make sure that these technological advances are distilled down to medicine for all. It cannot just be medicine for the people that have the best type of health insurance or for people that can't afford to pay out of pocket. Initially, that makes perfect sense, right? Because that's the way that we're generating data. That's the way that we're collecting and improving the technology. But we must commit ourselves to making sure that these advances are advances that reach all of us. And so let's contextualize a little bit, in the context of a disease or a pathology that's affecting all of us in this room. Inflammation. In some ways, I think the Arthritis Center was a pioneer in recognizing how immune dysfunction and uncontrolled inflammation was the driver of many of the pathologies, affecting the people associated, with this center. But now we recognize that every single pathology is attached to inflammation. It's not just arthritis, it's not just scleroderma, it's not just lupus, it's everything. And so every organ is susceptible to all these inflammatory responses, and the nuance attached to this, and this is where precision medicine can make a huge advantage, is that the immune system does not work the same in every organ. Because the functionality of that immune system is contextualized to the site of action that the event is taking place. So what's happening in a joint is one form of inflammation that may or may not be the same as the inflammation that is happening in an Alzheimer's brain. And precision medicine can help answer that question. And I'll give you some example related to that. So here is Miss Casion, actually case 1 for you. And this is a patient that was suffering from chronic inflammation for years. She's a 52-year-old that was otherwise healthy. And she decided that the current medical treatment that she was getting from, for the chronic inflammation that she had for years was not being managed, adequately by the conventional standards of care. And she decided to pursue alternative modalities for care, i.e. integrative approaches to chronic inflammatory, management. She presented with fatigue and extreme body pain, something that some of people in the audience might actually can relate to. And she actually had been treated successfully for a granulosa cell tumor back in 2011. She continued to have experiences with some ongoing health issues, all of them related to that inflammatory response, and she decided to take, action. Multiple integrative approaches were used to manage Ms. Casion, all successfully integrated into her standards of care. But the most important intervention that was made was an anti-inflammatory diet. And so the lesson to come from this particular example is that something that's under your control, something that you could manage and appreciate, is the intervention that made the most difference in the care of this particular patient. That does open a can of worms because foods are not all the same. Human bodies don't respond always the same to the nutrients that we take. And so there is precision nutrition as a field evolving right now. In fact, I believe that UA has a program in precision nutrition that we need to make sure that we promote and that we elevate, in recognition, because that's the next frontier. Integrative medicine, as great as integrative medicine is, and as valuable as those interventions are, suffer from the same problem that conventional standards of care do, which is one size does not fit all. And so we're going to have to take precision approaches to understand responses to integrative care intervention. And here's an example of what I mean by that. what you see on the slide, on that side of the slide, is something that we call an interactome. Is essentially a network of genes in an individual. And so, for the purposes of the example that I want to give you, A is patient A, B is patient B, and so forth, C and D. What can you see in that interactome for A, B, C, and D? That they're all different, right? And yet, all of those interactomes are inflammatory responses. And so what that tells you is that the network of genes in the human body for patient A that gets engaged in that inflammatory response is not the same network of genes that was engaged in the next patient or in the other patient. And that's where precision medicine becomes important. Because if I, as a provider, know that you fall under A, the intervention that I'm going to put in place is going to be an intervention that I know is going to work for A. And the same pattern, repeats itself. And so you can imagine the complexity that's associated with making this type of resolution on a clinical encounter for every patient that you see when they come through the door. That's why this type of approach has to be done preemptively. That's why we need artificial intelligence. That's why we need computers, because that interactome can be generated before you walk into the office. And then the clinical decision support that I alluded to as one of the tools of precision medicine can actually help the provider identify what the options are that might actually treat that particular interactome that you have there. So this type of work has been advanced mostly in the precision oncology space. You could not imagine having a cancer diagnosis today without a genomic workup in that particular cancer, to understand the biology that's driving that particular tumor. There's a lot of nuances attached to that because tumors don't stay the same, because people after treatment, their tumor changes, because the disease can manifest itself in a different way down the road. But the important point about it is that we now have tools that can actually help us understand those transitions. And so hopefully that's what your digital twin will be able to do. Your digital twin will be able to generate that picture before you actually walk into the office. Isn't that exciting? Here is a cartoon that shows you what an inflammatory response looks like. Obviously, I'm not going to go through the details of that response. The only point that I wanted to make there is that one of the reasons why there's 4 interactomes for 4 different patients all having inflammatory joint problems is because the behavior of the cells involved in the immune response is not always the same. So those of us that studied, immunology learn macrophages do X, Y, and Z. And that's what the textbook says. But there's one problem now. You know how many types of macrophages are out there? 10. And in a conventional medical encounter, we don't know what type of macrophage you have. And macrophages are the cells that put out chemicals that cause inflammation, but they also eat and digest debris in the tissue. So you need those macrophages to behave the way that they need to behave. And you have macrophages that behave well, and you have macrophages that behave not so well. And so having a clarity of understanding, that's what precision medicine can give you. And so that takes us to another important hallmark of precision medicine, biomarkers. I would say the 2 most actionable elements of precision medicine that we have today are pharmacogenomics, the customization of drug therapy on the basis of your genome, and the use of biomarkers to either diagnose follow trajectory of illness, understand recurrence, and understands lack of response to treatment. But we are very short on that journey. We still, when we study inflammation, we still use those biomarkers that are listed here. And those are the same biomarkers that have been used for the past 25 years. I put next to it other biomarkers that we might be able to explore, and the idea is that we need to continue exploration and fundamental discovery in the precision medicine space to come up with better biomarkers. And then, how many of you saw in the national news the case of CRISPR gene-edited treatment of a child that just came out? I think many of you saw that news. Well, here it is. 10 years ago, when I stood in front of an audience just as you to talk about precision medicine, CRISPR gene editing was only a promise. Oh, there's this technology that you might be able to use that enables you to edit genes when they're faulty. Well, here it is. And this is technology that's readily amenable for intervention. If you know what the genetic deficit is, then you could treat it. And I'm actually doing experiments right now to try to edit the epigenome component to disease. And the value of that is because most disease is actually an epigenetic disease, not a genetic disease. Doing CRISPR gene editing on the epigenome will enable us to change trajectory of illness. And so we're not too far from there. And I would assume that in 10 years, this is going to be something that's going to have penetrated the system. And now, in getting us a little bit closer to the end of my talk, I wanted to spend a little bit of time talking about aging and healthy aging. Because in many ways, well, all of us probably care about that, right? That's something that, well, what can I do to make this better? Well, the lessons that we already talked about, which is use your mind to keep yourselves healthy, making the right choices, and doing the things that we know can increase quality of life and improve, longevity. And so, what are those? Nutrition, physical activity, sleep, Susan would say breathing, managing stress, optimism, and social support. Now, clinicians 20 years ago might have not been receptive to a patient walking in and talking about using the power of the mind to heal itself. I think that maybe that thinking might have changed by now. I think at the very least, the most skeptical clinical provider would say, you may have a point. There may be something to that. But one thing that we have not appreciated, for instance, is how your mind and your spirituality and the mind-body-spirit connection influences your immune system, for instance. We did not know that before, right? We did not know that your mind could actually influence the way that your macrophages work. And remember when I told you about the 10 types of macrophages, that maybe you could actually use your mind to shift those macrophages to where they need to be. Now we know that is true. The other thing we didn't know 10 years ago is how the bacteria in your gut changes the way that your body works. How your microbiome is actually influencing your genes. And so now we talk about a gut-brain axis. And the gut-brain axis is the latest, most innovative approach that's being used to manage Alzheimer's disease. Who would have imagined that 10 years ago? And so a lot of what I think has been promoted by the Arthritis Center actually is a lot of what we need to be promoting in every single chronic disease management principle. And so hopefully, in 20 years, the pills that we take are not going to be pills to treat the pain that you have, but they're going to be pills that will actually enable your body to preserve and maintain quality of functionality of the cells in your system and the efficiency with which those interventions actually work. And so, Todd, pharmacology might have to change from the small molecule drug action intervention that we have, studied for years into how do we generate new drugs that basically are designed to preserve the health of the individual in years to come. And AI might actually end up working with that. So that yin-yang, of course, leaves us with a take-home message, which is balance is really the key to preservation of health. You have seen what Tracy so kindly promoted on your tables. That actually is the cover of a book on precision medicine. It's called Comprehensive Precision Medicine. I was privileged to be the editor for it, but you'll probably be very happy to know that there's a lot of University of Arizona contributors to that series. It's a 2-volume series that has, quote, everything you ever wanted to know. Nearly everything you wanted to know about precision medicine. So if any of you are interested, you should take advantage of and check it online. And then, of course, close the talk by thanking, family at home and at work. I would not be able to do the things that I do if I didn't have support both from my family as well as my colleagues, including many of the people in the audience right now, my collaborators, and then, of course, funding agencies. And I'll take the liberty of making a pitch for please let your Congress people know the importance of research funding and medical advances. It's, as you know, in danger right now, and I think we need to make sure that we convey that we speak with one voice about the importance of sustaining those resources to be able to sustain not only precision medicine, but the quality of life that we all enjoy here in this country. And with that, thank you for your attention, and look forward to a Q&A.
Thank you so much, Ken. It is such a privilege for us to welcome Dr. Ramos back. As he mentioned, we had the privilege of working together with one of his colleagues, Valerie Scheibele, who is here with us today in 2019. And needless to say, we were all very sad when he left, and that was one of the reasons that we wanted to make sure that we continued to educate our audiences on the great work that is happening in precision medicine led by Dr. Ramos. So we are so grateful that you made the trip back from Texas. Stay up there. So we are now going to go into our question and answer forum. We have quite a few questions from our online audiences. And just a reminder for those of you in person that you have your question cards in your packets, so feel free. We have volunteers and staff going through the audience. So we will begin. So the first one, Dr. Ramos, is on the slide that showed 45% of DNA sequences being mobile. What do those smaller slices represent? Different organs or physiological systems?
The smaller sizes on the pie diagram reflect the different types of mobile sequences which are present in the human genome. I only highlighted the ones that I study. That's a little bit of selfishness there. I study the ones that represent 20%, and those are called line 1 elements. These are long interspersed nuclear elements in the genome, and that represents 20%. And the other smaller pieces in the pie are different types of mobile elements, some of which are DNA-based transposons, and not in the same family as the line 1 elements are. Suffice it to say that independent of the classification of those elements, all of them have the ability to move around from one side of the genome to another. And in so doing, remodel the way that the genome is structured, and of course, change the functionality of the genome.
Thank you. So next question. This is a very interesting and excellent question. Will patients be informed about what medical information or interpretation is generated via AI and what data is reviewed by their physician?
That's a fantastic question. That is part of what remains to be developed, in the context of, regulatory decision-making for the integration of AI into medicine. We are actually, in my own program in Texas, piloting a platform. I will not mention it so that I don't promote it, unnecessarily, but suffice it to say that it's a platform that allows patients to retain full control of any AI machine learning generated data that is housed within the memory of this particular algorithm that we are testing. And the reason that we're engaged in that is because we want to demonstrate that if there is agency and patient governance of the data that's generated and stored in computers, then actually confidence will be built, and patients will be empowered to actually engage more in clinical trials, engage more in clinical research activity, and be able to interpret the data that's generated from the artificial intelligence platforms. The right thing to do is, of course, to allow patients to actually have that data, under their control. And the beauty, I think, of the platform that we are pilot testing is that if they decide to revoke that consent, they actually have the capability to do so, not only by removing the consent, but by actually extracting the data away from the platform and storing them on their own.
Thank you so much. So this is these are phenomenal questions. So with the goal and mission of precision medicine, how do patients navigate when they have providers in many different entities, private practice, all over, maybe all across town? How can the new Outlook help with coordinating data so that everybody's speaking the same language?
A fantastic question, I agree. And certainly one of the biggest challenges that we continue to face, in the healthcare industry, because of lack of portability, if you would. Some progress has been made in terms of being able to allow patients to bring their own records, to the different providers that they have. But the fact that we do not have a universal healthcare system creates challenges, in terms of how that data is integrated. Your best shot is to actually make sure that you, for meaningful pieces of your electronic health record, that you create the portability by making sure that there is transfer of information from one provider system to another provider system. Now, the good news is that the interoperability of electronic healthcare databases has improved to the point that you could now integrate disparate systems into one in ways that the data transfer actually is efficient and intact without being corrupted. And the portability of those data sets is actually currently being sort of tested at a national scale. And so hopefully good news will be coming down the road, but it definitely is one of the weak links right now in the delivery of precision approaches and in the integration of healthcare services throughout the country.
Thank you. So we were all very interested in hearing about the digital twin. So how far off is that?
It's been tested in research settings. We actually are building a program on digital twins through the ARPA-H initiative that many of you might have heard. It's right now somewhat on hold, but we're optimistic that maybe it will continue. But a lot of it is really still at the research level. It's not being used, in the clinical setting. As many of you recognize, clinical utility is not easy to come by because it requires numbers. And so we're working slowly towards making sure that that becomes a reality. My prediction is in about 10 years.
Thank you so much. So another excellent question. How are physicians being trained today on the latest in precision medicine and medical technology, i.e. AI? And what are the key biomarkers in OA and RA that we should know about? Are new biomarkers being developed?
Okay, that's two questions in one. Regarding medical training, we're making progress. I mean, we have a savvy, population of students entering, the medical field. Todd, I'm sure you could relate to the fact that they know about computers more than we know, and that when we run into AA issues in the class, they actually are the ones that solve the problem. So I think that they have the know-how to be able to do it. There's going to have to be some curricular reform coming down the pike, mainly because enough of genomic medicine has not yet been fully integrated into conventional, medical training, but that's in the works. Chances are that a lot of the genomic medicine knowledge is going to be acquired post-medical training, in residency and fellowship training for people that will actually need to specialize in that particular space. But certainly some appreciation and understanding of clinical decision support algorithms that use precision medicine, I think is going to be important that our trainees actually, acquire. And then the last comment that I'll make related to that is schools are beginning to sprout, creating a new type of physician. A&M, the university that I'm with right now, is the second one in the nation to create a program that's called engineering medicine. Basically, this is a recruitment of people to go into the healthcare profession of medicine, but having had an engineering background before they come into training, meaning they're going to bring an engineering mindset into the practice of medicine with the idea that they would be physicians more inclined to be the physicians that adopt and develop further precision medicine as a field. And then that will become essentially like a specialty practice in which these individuals can operate. I'm pointing this out because the university up the road just opened an engineering medicine program that might create some interesting challenges, for medical training in the States. So U of A must remain attentive, to that. And then with regards to the second question regarding biomarkers, many of them are in the works. In terms of, more sensitive, more precise, and more specific, biomarkers for osteoarthritis. Many of them are in the realm of understanding oxidative stress, and the reason for that is because inflammation, the way that inflammation damages tissues is through something that we call oxidative stress, much like the rust that happens in metal. Well, that same kind of chemical reaction is what happens inside cells and damaging proteins. And so many of those sensitive biomarkers might actually be readouts of oxidative status, in cells. And so more to come on that particular line.
So we have so many questions that I'm sorry we won't be able to get to all of them, but that just means you're going to have to come back another time.
Happy to do so.
That? So we will take our last question in order to stay on schedule, and this is an excellent one as well. How close are we to implementing genomics or precise biomarkers in selecting best practices? And I know we'll be talking about this in the panel for pharmacogenomics and the like.
It's been done already. This is no longer a promise. This is something that's actually already being used in clinical practice. It's penetrated different specialty areas to different degrees, meaning that it's not pervasive, in all specialties, but the most in need of using pharmacogenomics are actually using, and perhaps the best example that I can give you is in the psychiatric healthcare space. Most psychiatric health practices are now utilizing pharmacogenomics in a pretty aggressive way, because many of the medications that are used to treat psychiatric conditions are very susceptible to not working effectively for every patient. And so having that preemptive knowledge in psychiatry has become essentially transformative to the practice of psychiatry. As I said, oncology is actually using it with enough regularity, especially for certain medications. And so the good news about it is that the technology is dropped in cost significantly. I mean, you could easily get one of these pharmacogenomic tests for $200, which is a very reasonable amount of money. And we are continuing to work with payers to make sure that they recognize the value of having preemptive pharmacogenomic information for their patients that they're insuring, because that's going to help them make better decisions. It's not universal, but I'm pretty confident that this will be one of the first areas where precision medicine is going to penetrate in a meaningful way.
It's very exciting, and we are so looking forward to the future and developments in your research. So if I may now, I'd like to invite Amy Voles-Jobst, who is the daughter of co-founder Dr. Robert Voles, to present a thank you to Dr. Ramos for his amazing leadership of today's keynote and symposium. So many of you have heard us reference, this is the Eva M. Holtby Endowed Keynote presentation. The Friends at the University of Arizona Arthritis Center was founded by Eva Holtby in 1997. Mrs. Holtby's outreach to the Tucson community led to a wide circle of admiring friends drawn to her strong leadership skills and her care for those in need. It was her steadfast leadership and vision that gave birth to the concept that through education, public awareness, and community involvement, organizations like the Friends of the Arthritis Center could build community support and make a significant contribution to improving the quality of life for those afflicted by arthritis. That mission has become the cornerstone for the diversified efforts of the members of the Friends for more than 25 years. Each year, contributions from the Friends support the UAAC's wide variety of activities and interest. And Mrs. Ann Voles was a dear and close friend of Eva Holtby, and it is our honor each year at our annual symposium to introduce and welcome our Eva M. Holtby Endowed Keynote presenter. And Dr. Ramos, how grateful we are that once again you were that keynote presenter.
Thank you for having me.
Thank you so very much.